So you use the transverse or transverse incision or straight one? 是直的纵切口还是横切口？你是横切口是吧？
横切口的啊。我们剥离一下，来寻找一下这个中央型的突出。Maybe this is the central disc herniation.
So very good. So this contralateral approach also can be used to treat the cervical disease. We can do the contralateral foraminal decompression. Use this approach. Yeah.
I have tried the cervical third portal or the URBD.
Yeah.
I also use the third portal in the single open door, the cervical procedure, for the insertion of the screw and the plate.
Yes, very good. Good job, great job.
Thank you.
我稍微中文说一下，就是这个对侧入路啊，可能有一些中国的医生也不是特别熟悉，因为这个呢相对用的比较少，但是呢，对侧入路可以保留这个对侧的关节突啊，在达到同样切除这种减压或者切除椎间盘的情况下，像这个病例呢，张伟教授他就是为了保留这个稳定性，因为我们只是单纯减压，所以呢，他从对侧入路可以保留更多的关节突。尤其是利用这种30度的镜子啊，所以充分的利用这个30度的镜子，这个呢，大家在颈椎上，像韩国的教授也有就对侧椎间孔减压，保留更多的这种关节突，包括张伟教授这个拓展，他用这个做这个颈椎的甚至椎板那个就是椎管的扩大成型啊，甚至在第3切口，包括第3切口的这个拓展应用啊，就是说。我们将来这个内镜啊，双通道内镜啊，不一定是双通道，2个切口可以是3个切口，甚至将来可能会有更多机器人的手术加进来的话，4个切口都有可能啊。这为了我们手术的这个需要啊，我觉得这都是我们可能将来需要大家去拓展。So, Dr. Wu, do you use third incision in your practice?
So far, I haven't used the incision in my practice. I do contralateral approach, and I agree it's very difficult to get central disc from a contralateral approach, from biportal or uniportal. So in this case, I probably do transforaminal because I do both type of scopes. But I think it's a very nice and beautiful surgery done by Professor Zhang Wei. Very nice to watch.
Okay, thank you. So another question from the audience. What are some of the patient-related factors that are contraindicated to UBE? Dr. Liu?
Contraindication. Some patients not tolerant to general anesthesia. Maybe as the contraindication.
So also, another from Dr. Chang. In case that the general anesthesia is not recommended, any comment with high-level lumbar anesthesia. You have some experience. Okay. Dr. Liu.
对，
是其他的硬膜外的行不行？你谈谈吧，应该是这个意思吗？
对，就是contraindication included high degree spondylolisthesis of lumbar spine. maybe 3 or 3 to 4 degree spondylolisthesis.
To match the blood vessel on the surface of the disc fragment. No, I find the disc fragment.
Okay, great job.
But I will do the bleeding control first.
So now the radial frequency is through the third portal.
But the left upper about 11 o'clock.
So Dr. Zhang Wei.
Okay.
So the radial frequency is through the third portal or the left portal?
The left portal.
Okay.
I will change.
Okay.
Maybe sometimes I will use the third, and sometimes I use the obsilateral portal.
I mean, if you change the portal, you should told us.
Okay. Because I insert the endoscopy too deep, so you will not see the which is the third portal, which is the obsilateral portal.
Yes. 就刚才跟张伟教授讲，他哪个切口放器械跟我们讲，尤其从第三切口，我们要认真学习一下，因为这是张教授对我们双通道内镜的一个非常大的贡献。提出这个transportal 也在国际上也得到一个认可，也是我们中国人的骄傲。
Yeah, this is the lower part of the disc fragment. Very big.
So the hook is held by the assistant.
Obsilateral portal. I insert the retractor through the obsilateral portal.
OK， 是助手帮你拿的吧 ？Assistant.
Yeah. Assistant.
Very good
Then,
assistant.
I use the yellow one to open the membrane on the disc fragment.
我觉得这个助手的拉钩拉得非常好，你有非常好的助手。
对，
小猪在夸你拉得非常好。
真的，确实拉得非常好。很稳啊 ，very stable。
This is the third portal.
OK，
Okay. I open the membrane.
yes.
If I remove the fragment totally, this is a simple case procedure, I think. Maybe I will remove the disc fragment totally, I think.
So Dr. Zhang Wei, how do you think about if you stand left side but do the incision in the right side, two portal, like Dr. San's approach? So compared to your approach.
I use the contralateral side portal to remove the up margin of the laminar. Then I think there is enough the surgical field. But for this case, maybe the obsilateral portal is enough, I think.
我也不太懂，我就用中文再跟你说一下，因为我不知道你理解，就你像 Dr. Sun 这样， 他原来不是也有这种站在左侧做右侧的这个编排吗？跟你这个站在从左侧做切口，他是右侧做切口吗？就这两个如果做这个有什么不一样吗？
它的这样的话，它对于这个椎间孔区域显露的范围不是特别广，但是像但是像去做这种游离的是没问题的，但是它可能只是看到硬膜和出口根的腋窝这里。
就在斜的角度不够大，没有看外侧看的大一些，是吧 ？OK。
We are very lucky. We will remove the disc fragment totally. Maybe the last one is disc herniation in the foraminal area, the upper part of the disc fragment.
Okay, I will translate into English.
Okay.
那我刚才有问题啊，再用英文再说一遍吧，可能有些人我刚才没表达清楚啊。这个我觉得挺好的。So I asked Dr. Zhang Wei. Dr. Zhang has some showed approach. He stand left side, but do the two portal in the right side. But Dr. Zhang Wei's approach is he did the two portal in the left side, but the third portal in the right side. So what's the difference? So Dr. Zhang Wei, he said maybe the two approach is same to do the lower the sequestered fragment downward, but to do the foraminal disc fragment, maybe Dr. Zhang Wei, he can see more in the foraminal area. Okay?
Okay.
Thank you. Learn a lot from you. Thank you very much, Dr. Zhang Wei.
Thank you, Dr. Yu, for the introduction of the whole procedure. This is disc space.
Now you do the foraminal area.
You can see the left side of the membrane. Maybe I have removed the disc fragment in the foraminal area.
Okay.
But I will probe the existing nerve root.
Good job.
我可以看到这个膜，我可能已经把这个咽孔区域的这个游离的髓核给它摘除了，但是我需要再去探查一下这个触骨根，因为我们看到这个左侧的这个膜底下已经是空了。There is too much the fat tissue and the blood vessel in the axillary area of the existing nerve root. So this is they are all the important landmark. You can see the tip of the SAP and the foraminal area flav ligament. 我们可以看到这个椎间孔区域的黄韧带，还有这个上关元素的尖儿。
对，这个张伟教授刚才讲，你这个地方有很多的这种这个脂肪是吧？这个上关元的肩部就提示这个对侧的凸形根是一个解剖标记。一个呢就是我们到这个区域，第二个要注意损伤。这个呢可能国内做这个双通道的医生呢，对这个对侧入耳我觉得相对不太熟悉。我知道刘正教授还是做了一些。所以呢，就是应该是讲的，今天非常感谢张伟教授给大家演示这么一个手术应该讲还是非常有意思的 case。Thank you。
谢谢于可一教授和刘正教授。我的这个可能这个上方这个切除还不是特别够。今天我们这个椎间孔区域呢，我们就用的这个带弧度的这个腔钳来处理了。因为直的腔钳处理这个地方确实有困难。
OK。
于可一教授可以翻译一下
Okay. So Dr. Zhang Wei said for the contralateral approach, to resect the SAP, the proximal XCP use the curved keratome. So if you use straight one, it's difficult. So he used this keratome, curved keratome in this area. To answer Dr. from the Indonesia, OK？ 刚才有个印度尼西亚的我们的教授，刚才问了这个问题啊。
If we remove the tip of the SAP, we can expose the long part of the existing nerve root.
So, would you prefer to use ostium or curettage？ 你对用骨刀或者这个刮齿处理这个区域有什么？
刮齿可能对于处理黄韧带好一点，骨刀的话最好是用这种曲棍球一样的这种骨刀来处理上关节突的尖儿还好一点。但是我觉得这个病例的话，可能它有足够的空间，上关节突我去除的也不是特别多。
OK，
主要还是用这种带曲度的椎板桡骨钳来去处理。
So Dr. Chang's question: Any comment on the feasibility of a proper annular repair or suture after discectomy? Use UBE?
You mean the annular fibrous suture?
Yes.
Maybe I will try. Maybe I will try the contralateral approach, the annular fibrous suture. But I do many cases with the apsilateral annular fibrous suture.
So I think it's easier to do the UBE technique is easier compared to the uniportal one. So,
Yes. 就是说是对侧的纤维环缝合，经过对侧入路的纤维环缝合，我们在将来会尝试的。但是同侧我们做了很多纤维环缝合，但我觉得这不存在什么技术上的这个困难，这个应该也是比较好缝的。如果你确实是对侧这种入路很难缝的话，你可以是经过辅助切口来去缝啊。
那观众的这个上他意思就是对这个单通道的也可以做缝合啊 ，monoportal， 但是双通道显然做最近显微环缝合更加容易，
更加舒服一点。我们甚至是做这种裂口位于这个下方的，就是椎体上缘的这种缝合。我们用的铆钉线，还有结合2020公司的这种普通的缝合线进行的缝合的，也能把这个裂口啊闭合的非常好。This is existing nerve root.
So all this while you are using curved keratome, right, Professor Zhang?
Yes, this is a curved keratome punch. Because if you use the straight keratome punch, I think is not good. You cannot remove the flavial ligament and the bone. But maybe the shape of the bone.
So this curved radio frequency is a very good instrument.
Yeah, yeah. Is small size and curve. So
这个是做颈椎也是不是像新开发出来的是吧？
对，做颈椎的它是现在可调节方向的。
对对对。
啊，
所以这个是他们设计的新的这个射频，
对，
比较细，同时呢可以折弯，是吧？这个
对，可以根据你的需要来去折弯。有的时候它固定角度你这个角度对你来说不合适，你可以自己调一个角度，都是非常不错的啊。
So this is a flexible one. It can bend according to what you like.
Yeah. Adjustable radio frequency.
Yeah, good one.
Yeah, we can see the L4 nerve root. This is the L4 nerve root.
Yeah, very clear.
The existing nerve root.
看到这个视野中心的这个就是出行根了，腰式出行根啊。现在由于它是一个斜的这个方向看的，所以保留了关节突啊。
对，我们是从椎板下表面这样过去的，所以它对稳定性破坏不多。你可以看到我们的也就是一个腔前的破坏程度，所以这个稳定性是没问题的。
所以这个在某种程度上，它这个破坏程度啊，比单通道就椎间孔入入的这个关节突的破坏可能还更少一点啊，可以这么说啊。
现在那个韩国的年会上，他们说是甚至是做孔外的突出，都是经过这个入路来去掏孔外的，可能会对上关节突这个地方肩部破坏的更多一些，可能会看这个触骨根看得更广一些。
So Dr. Wu?
Yes.
Do you think about, this approach preserved more facet joint compared to the transforaminal approach, the monoportal?
I find that I will use this approach. I do use this approach both using uniportal and biportal. If there is a concurrent lateral recess stenosis, rather than extraforaminal disc, I think this is the best approach. If you have a lateral recess plus a foraminal disc, or lateral recess stenosis plus foraminal stenosis. And in between uniportal and biportal, I find that biportal is very much more efficient. Uniportal, I tend to use a very small scope and to do this, and it takes a bit of more time. Both can achieve the same objective. But if extraforaminal disc, I think I would either do a far lateral approach in biportal or transforaminal approach. In terms of SAP preservation, I think to be fair, both I think can preserve the SAP. It's just different part of SAP that is being preserved. For the contralateral approach in biportal, I will preserve the lateral and dorsal aspect of the SAP, while with the transforaminal approach, we preserve we only take the front, the ventral part. So I think the dorsal part of the SAP is preserved. I think both are stable.
Okay. Thank you for your comment.
Professor Zhang, Professor Yu, there's a paper published last August, in August last year, written by Donghua Xu. He introduced the contralateral subliminal approach for decompression of the combined lateral recess, foraminal and extraforaminal lesions. Use UBE, and he shows a good result.
Yeah, I will probe this area and open the membrane. I want to see is there another fragment. I think I will finish the procedure.
Yeah.
There is not, maybe there is nothing, nothing there in this area. You can maybe I have removed the disc fragment totally.
Okay.
Okay, thank you everyone. I will finish the operation.
Okay. Great job.
Thank you, thank you.
So now we can also to have some discussion. So there's Dr. Om Patel. So his question is, what are the commonly seen complications in UBE surgery while adapting to UB technique? Adhesions, endocondilitis, infections, residual back pain. So maybe Dr. Liu and Dr. Wu to answer this question.
I have some complications by UB surgery. I have 2 cases of rupture of tubular matter. 2 cases, and I have 2 cases of inadequate remove of disc herniation of discs.
How about the Dr. Wu? What's your comment? Suggestion?
I think in the early phase of our training, the dural tear can be more common, and incomplete decompression are the common causes of complication. Later part, I think, because I personally do not use drain, so I have 2 cases of hematoma. Both doesn't need any revision surgery. For the dural tear, I repair them using tackle seal method. I think we can also repair them using sutures through the biportal approach. These are common, these are the complications I've seen in my cases.
Okay. So how about the future trends in ESS could be robotic overseas UBE surgeries, mentorship, training? So maybe I think UBE means 2 portal, but in my opinion, and like Dr. Zhang, now in this case he used 3 portals. So we use 1 portal, 2 portals, 3 portals. It depends on the technique and the disease conditions. So maybe in the future, I mean, if you look at the Da Vinci robotic surgery in the abdomen, they use 4 or 5 portals. So if we use robotic surgery in spine surgery, for nowadays we only use for pedicle screw insertion, not truly use it to decompression to do some nerve work. So maybe in the future we can do more. Like you know, I once tried to use so-called endoscopic assist or arthroscopic assisted hemivertebral resection. It's useful to see more in the abdomen ventral side, and also we can remove the ventral cortex bone. It's very clear. Maybe in the future we can use like the UB technique developed. In the future we can use it to do more, like hemivertebral resection, tumor resection. So maybe we need more portals. So, and then we use compared endoscopic combined with robotic surgery. So I think it's just the beginning of the endoscopic spine surgery. In the future, we can do more. So what's the expert panel view on getting repeat MI after surgery? What should the minimum time interval for the repeat MI? Dr. Wu?
If you use the drain, then you can repeat early. You can repeat next day, the day after. They look fine. If you like I myself, I don't use any drain for biportal, all cases, even fusion. So I don't, if there's no symptom, I don't repeat them in the first 2 weeks. I do them in a month. Then it looks clearer.
Okay, how about Dr. Mohammed from NDC? Hamantia. Are you still online?
Yeah, thank you. So I don't frequently do the repeat MRI. I only see the patient symptoms. If the patient symptoms doesn't disappear, then I do the MRI. But if you want to do a study or report your experience, then you do the MRI. Because I always use the drain, I do the MRI the day after, and also the 2 weeks follow up. So based on the clinical symptoms of the patient, if there's no, is pain-free, I don't do a MRI. But if you want to do a report or study, then you do an MRI.
Okay, thank you. How about Dr. Liu?
We will give patients MRI scan post-operative 1 month post-operative, 1 month post-operative. Yeah.
Okay. So I usually, how about Dr. Yoshimuzi?
Yes, I always check the MRI after 3 months after surgery. Always. Sometimes I do before 3 months. Patients have some doubt of recurrence. I will perform more earlier.
Okay. So how about the insurance company to pay for that?
Sometimes I have to write some letter for insurance. It's too early to perform. Yeah.
Because we in China the MI is very cheap, 500 yuan, maybe just $80. So maybe in the United States, maybe $2,000. So it's different. How about in Singapore and in Indonesia? How about the MI for once?
How much first?
How much?
So for Indonesia, it's about $200.
Okay, it's maybe in the past, maybe China, maybe 100 or 150, but nowadays it decreased. The government regulation now maybe I know in Beijing maybe just only maybe 80， 是吧？880美元差不多吧，400多，有这样。
$80.
How about in Singapore?
Singapore is about $300.
Okay.
300 to 400. So half of my patients refuse to do scan. Yeah. Actually, more than half. I have to really try very hard to get someone to do a scan, really.
Okay.
Yeah.
Dr. Abraham, maybe from how do you teach trainees in the UB skills? Dr. Liu, what's your plan for the beginners? What's your advice to learn the UBE?
If I give lectures and show live surgery like Professor Zhang Wei, and will perform the mimic surgeries in animals.
So how many patient doctors in Indonesia they start do the UBE? What about the percentage in Indonesia, Japan, and Singapore.
What's the question?
I mean, how many doctors,
Ah.
surgeons now begin to do endoscopy, or especially in UBE? How many surgeons?
So in Indonesia, UBE is a new trend now. So maybe 5 years ago, we start with the 5 or 6 years ago, we start with the Uniportal, and 3 or 4 years until now, we start to do the Biportal technique. And all of the surgeons favor for the UBE because most of all feel it's more comfortable for the beginning, and for the general hospital it's more cheap. It's cheaper to do the UBE compared to the Uniportal technique. So nowadays many spine surgeon in Indonesia favor the UBE compared to the Uniportal.
How about in Japan?
Actually, very little doctors perform biportal technique actually in Japan. I'm having a hard time how to spread this technique in Japan. It's very hard to expand it. The problem is originated from maybe adaptation of tools, especially about endoscope. It's very hard to introduce this technique in Japan, actually.
How about in Singapore, Dr. Wu?
Actually, there are, I think, less than 10 biportal surgeons in Singapore. Quite a number of them actually come from my hospital. I mean, there's quite a number of uniportal surgeons. They tend to do for discectomy. I think there's a lot of reasons for the comfort level with tubular surgery, and the comfort level of being good at what you are doing, and then getting to learn a new technique is a challenge, I think. And in Singapore, we have very low tolerance of any complications, or the medical legal climate is quite significant. So it takes a lot of courage to do a new technique.
Okay.
So yeah, that's the reason why. There's a lot more interest now in the younger generation. I think in the younger generation, they can choose between tubular, because they start from a fresh, right? Just graduate, they just become spine surgeon. Then they have to make a decision whether if they do MIS, they want to do tubular or scope. Then in that way, quite a number of people choosing between uniportal or biportal, quite a number choose biportal because the learning curve may not be so steep. So that's the reason.
Okay. So in my opinion, is in Asian country, the endoscopic spine surgery is more popular compared to United States and also Europe. So, and in China, more and more spine surgeons now do endoscopic surgery. And usually to learn the so-called monoportal endoscope is more difficult. So nowadays in China, more and more spine surgeons, they used to do open surgery. They now learn how to do UBE, so the biportal. So maybe, I think maybe nowadays, maybe 20% spine surgeons now do endoscopic spine surgery, almost, I think, maybe, but I think maybe 5 or 10 years later, maybe it's nearly 60 or 70%. It's our future, I think. I think the UB technique can promote the percentage of the endoscopic spine surgeons. Because after the introduction of the transforaminal endoscopic surgery We started in 1998. Dr. Zhou Dewei, Dr. Zhang Xifeng. Nowadays, maybe 20 or 24 years late or past. But nowadays, biportal endoscopic to promote the percentage very significantly. Yes. So I hope. I think the endoscopic spine surgery is the future. So we should need more efforts to promote the percentage. So so which cases should be avoided in the early endoscopic spine surgery practice? Dr. Yoshimuzi, what's your opinion? The audience.
Yes, I think the compression surgery is always harder to compare with discectomy. In my opinion, endoscopic fusion surgery is more easier than decompression. This is my opinion. Yeah. First case should be L5S herniation is the best for the first case. I think it's all of opinion, I think.
Liu, what's your recommendation?
I would like to show some cases should be avoided in early endoscopic surgery. I would like to show some cases you could perform the early endoscopic spine surgery, like disc herniation and lateral recess stenosis. This is the first cases you could try first, and some cases you should be avoided, like this, some cases severe lumbar spinal stenosis, central canal stenosis, and high degree disc herniation, and like that.
How about Dr. Muhammad?
Yeah. So for your early cases, there's two types of cases that you want to see. First, the herniation type, and the second is the stenosis type. So for the herniation, you want to find a patient with simple disc herniation, L5S1. Start your cases with the L5S1 simple disc herniation. No downward, no upgrade migration of the disc. It's easy for you to practice for the herniation disc. And for the stenosis cases, you want to try L4-5 or probably L5S1. Avoid to do L2-3, L3-4, or even L1-2. Try to start your stenosis cases with the L4-5 or L5S1. And find the lateral recess stenosis or central stenosis. Don't do the foraminal stenosis for your first cases.
What about Dr. Wu? Your recommendation?
Yeah, so I think for the first 10 case, everybody is watching you, so find discectomy to do, because once you fetch the disc out, the patient feels better. You probably is a success. But I mean, after you do a number of successful cases, I would like that you should go for more challenging cases, because it's through challenging cases that you learn. So I had a tough time initially. And some more I dilute my cases. I do uniportal and biportal. So, but nevertheless, I choose the easier case, and then after 10 cases of each, I will just do every case. scope. Yeah, you just have to sometimes spend more time, but please allocate more time for yourself, and then try not to give up. Do not lease like T10 to pelvis after you lease the scope. You know, if you are first 10 case, I mean, then you stress yourself and you give up, and then you get very disheartened. So I think choose a discectomy initially, and then subsequently move to the harder cases.
Yeah, that's a good point from Professor Pound. Never give up, because usually my students for 1 hour they give up, 2 hours they give up. Try to never give up for your cases. Spend a lot of more time. You will get more the feeling by experience, but never give up. I agree.
Okay. So thank you all the guests. I think the biportal endoscopic surgery makes the endoscopic spine surgery easier when compared to the monoportal, and you need to step by step. And first, maybe discectomy. Dr. Yoshimoto said maybe endoscopic spinal fusion is easier to him, but most of them, most of us maybe start with discectomy. And maybe lateral recess stenosis and lumbar spine fusion, and also we can start to the cervical spine and to the maybe last step, maybe the thoracic spine decompression, because thoracic spine surgery is more dangerous. So thank you very much, and maybe we should close this panel. Okay, thank you. All the guests. Thank you. All the audience.
Thank you so much. See you later.
Bye-bye. See you later.